Assalamu alaikum. Good day for all. Today we will start abdominal anatomy. We will start with the abdominal wall and then go through the abdominal viscera and abdominal organs. Okay, generally we'll start with introduction of the abdomen. We always start to how we can divide the abdomen in general. The abdomen is divided in general in 9 regions by 3 planes. First plane is the vertical plane, which is the mid-clavicular plane, and the other 2 planes are the subcostal plane at the level of L3 and the intertubercular plane at the level of L5. The regions of the abdomen is, as you see, starting from right hypochondrium, epigastrium, left hypochondrium, lumbar, umbilical region, left lumbar, left right iliac fossa, hypogastrium, and left iliac fossa. These are for easy diagnosis and easy differential diagnosis for any complication, to just know in each region which organs and which parts of organs are situated, so I can easily approach my diagnosis. Okay, then what is the layer of the anterior abdominal wall? The anterior abdominal wall is formed mainly by skin, followed by fascia, followed by the muscles of the abdomen, then again another fascia transversalis, followed by the peritoneum, and then you go to the intraperitoneal cavity. Fascia, as we know, it is formed of 2 types of fascia. One of them is called the Camber's fascia. Camber's fascia, this is the superficial fatty layer, and this is the thick layer of fat you approach during your incision. And another layer called Scarbus fascia. Scarbus fascia, this is like a sheet, and it is more thin than the Camber's fascia. And by the way, it is in children, it is highly developed that you can think it is an aponeurosis or a muscle. Sometimes it is misunderstood in children where you're doing laparotomy or opening any incision, like it is a little bit thicker in children. Then go to the abdominal wall muscles. We have the external oblique muscle, followed by the internal oblique, followed by transversus abdominis muscle. Don't misunderstand this. External, then the internal. The internal is not the innermost. The innermost is the transversus abdominal muscle, followed by the fascia transversalis and the peritoneum. If we take an incision laterally away from the midline, these layers will be as we said. But if you go through the midline, we have condensation of these 3 muscles in what we called aponeurosis. And they are condensed around what is called rectus abdominis muscle, which is a longitudinal muscle present in the anterior midline of the trunk. Okay, so if you go through the midline, you'll go for skin, superficial fascia, then the anterior rectus sheath. If you go a little bit paramedian, followed by the muscle, followed by the posterior rectus sheath, followed by the posterior, followed by the rectus abdominis, followed by the posterior rectus sheath, then the transversalis fascia and peritoneum. If you go immediately or in the midline of the abdomen, all these muscles will be condensed in an aponeurotic line called the linea alba. So in the midline, you will find only the media alba. So during exploration, midline exploration, we just open skin, superficial fascia, and deep fascia, followed by the linea alba, then fascia transversalis, then the peritoneum. Okay. Muscles of the interior abdominal wall. You have three main muscles, which is the external oblique, external oblique, internal oblique, then transverse abdominis muscle, followed by the midline muscle we talked about, which is the rectus abdominis muscle. Arrangement of the fiber of each muscle is very important, and it's also very important to know the action of this muscle and knowing its origin and insertion. The external oblique muscle is like your pocket, coming from upward, then downward medially. Upward, then downward medially. Upward starts from the lower 8 reps, followed by insertion in the xiphoid process in the midline. Start from up, xiphoid process, linea alba, symphysis pubis, and the lateral or the outer lip of the anterior 2/3 of the iliac crest. The iliac crest has 3 lips: outer lip, intermediate lip, and inner lip for the 3 main muscles of the abdomen. The first one is insertion. The second and the third muscle are origin, gives origin to the second and third muscle, but gives insertion to the first muscle only, which is the external oblique. Then, nerve supply with the lower 6 intercostal nerves, from 7 to 11, plus the subcostal nerve. Internal oblique have a different direction for enforcement of the abdominal wall. So the first one was upward, coming from upward, then downward medial, but the internal oblique coming from downward and then go upward and medial. Let's imagine how comes the origin. The origin comes from the thoracolumbar fascia, the anterior 2/3 of the intermediate lip of the iliac crest, and also it takes an origin from the inguinal ligament, which is the reflected lower fibers of the external oblique, from the anterior superior iliac spine to the symphysis to the pubic tubercle. It takes some fibers, takes origin from the outer 2/3. Where it is inserted in the lower 3 to 4 ribs, plus the xiphoid process, plus linea alba, plus pubic crest. Just notice that all the muscles will be inserted or inserted in the xiphoid process, linea alba, and the pubis to form the linea alba, the condensed tenotic fibers of the 3 muscles in the midline of the linea alba. Also, it takes nerve supply from the lower 6 costal cartilage, plus the iliohypogastric and the ilioinguinal nerve. Notice that the iliohypogastric and ilioinguinal will give these 2 muscles also. The transverse abdominis muscle, also the innermost muscle, which will enforce the anterior abdominal wall. It comes from, its fibers first travel transversely, started from back or from the side or from the line, and then travel transversely to the midline, to the linea alba. From where its origin, it takes from lower 6 ribs, thoracoabdominal fascia, and the anterior 2/3 of the inner lip. So the intermediate lip gives insertion, the outer lip gives insertion to the external oblique, the intermediate lip gives insertion to the internal oblique, and the inner lip gives origin, so only the intermediate one gives insertion, and the first and the third one gives origin. Okay, sorry for this, just corrected. And from the inner lip of the anterior 2/3, plus also it takes part of the lateral third of the inguinal ligament. So the inguinal ligament gives lateral 2/3 give origin to the internal oblique, and the lateral lip, the lateral third gives origin to the transverse abdominis muscle. Where it is inserted, the same as we said, the xiphoid process, linea alba, and pubic crest. Nerve supply is the same, like internal oblique gives lower 6 intercostal nerve plus the iliohypogastric and ilioinguinal nerve. Just notice this, as we said, lateral 2/3 and lateral third of the inguinal ligament gives origin for some fibers of the internal, oblique, and transverse abdominis muscle. To put in mind, these fibers getting origin from here will be condensed together or will be fused together to form what is called the conjoined tendon. Conjoined tendon. We will talk about it later. Like this, you can imagine spherical spine, pubic, tubercle. This is inguinal ligament. This is part of the outer 2/3. This is the origin of the internal oblique, and then comes the transverse abdominis, go from the lower or outer third. Both together are condensed to form what is called the conjoined tendon that wrap around the roof or forms the roof of the inguinal canal. Forms the roof of the inguinal canal. Okay. The last muscle we have, which is the rectus abdominis muscle, and this muscle is septated muscle from the origin by two heads from downward from the pubic crest and the anterior pubic ligament from the pubis and go upward to be inserted in the xiphoid process and lower costal cartilage from 6 to 7 costal cartilage. Blood nerve supply from the lower 6 intercostal nerves. So all of them takes from the lower 6 plus the internal and transverse abdomen takes more supply from the iliohypogastric and ilioinguinal nerve. Okay. Let's go through the rectus abdominis muscle to know how the layers of this muscle. Rectus abdominis muscle, yes, just you imagine like a muscle coming from the pubis till this xiphoid process. And then the three muscles of the anterior abdominal wall come from lateral to make something like an envelope around these two muscles. They are two muscles, paramedian muscles. And then join again like an aponeurotic structure in the midline to form the linea alba. But what happens in these muscles on different levels? Much more important to us is a level at the umbilicus level and another level just below what is called the arcuate line. Arcuate line is a line between symphysis pubis, umbilicus, and just midway. This is called the arcuate line. This is called the arcuate line. What changes happen to this muscle? Let's go up. What is the normal structure of the most of the about 2/3 of the length of the rectus abdominis muscle and the rectus sheath? That the external oblique form a layer of the anterior rectus sheath. Internal oblique aponeurosis is split to envelope the rectus abdominis muscle. Split like, so I have this muscle, I have this muscle, this muscle. This muscle go to form the anterior rectus sheath, external oblique. The internal go split and form an envelope around the muscle. And we can imagine this is the muscle. And then the internal oblique comes to form the posterior, another posterior layer for the posterior rectus sheath, followed by the transversalis fascia or fascia transversalis. Okay, and all of them meet here to form the linea alba. This is the linea alba. What happened below the arcuate line? The arcuate line below the posterior rectus sheath disappear? And this is very important question in phalangeal incision. What happened exactly? That we have the same three muscles in the fascia transversalis. The anterior rectus, the external oblique will form the anterior rectus sheath. The internal oblique will form also the anterior rectus sheath, followed by the transverse abdominis, followed by the external or the anterior rectus sheath, and only the fascia transversalis will be down. And this is the muscle. So all of them will form the anterior rectus sheath, and there will be deficiency of anterior rectus sheath of posterior rectus sheath below the arcuate line. That's why when you open phalangeal incision, you go through skin, anterior rectus sheath, retract the muscle, and then go for the fascia transversalis, and you go intra-abdominally. Okay, so the layer after the retraction of the muscle is the fascia transversalis, no posterior rectus sheath. Okay, some surgical important points we will meet here in anatomy, and sometimes we'll meet it in surgical procedure, which is Kocher incision. What's Kocher incision? This is the incision for cholecystectomy, old cholecystectomy, open cholecystectomy. You do an incision like this. You see, we go through the rectus abdominis muscle, so we cut the muscle, we divide the muscle. We don't retract the muscle, we divide the muscle. Okay, this is the Kocher incision. In phalangeal incision, by the way, we open and then retract the two muscles. Retract the muscle to reach to the uterus or to reach to any pelvic organ. We don't cut the muscle here. Another importance, which is in paramedian or median incision. If I'm going to do an incision here, so paramedian or median incision, what I'll do for this muscle, I retract this muscle laterally. Why? Because this muscle takes its innervation from outside. Innervations through outside. So if I retract this muscle to the median or medially, I will cut all this innervation. So it's normally to retract this muscle to the lateral in each side. So I have a good approach to the abdomen without intervening with the nerve supply and even the blood supply of this abdomen, because I'm opening in the bloodless line, which is the linea alba. Blood supply for the rectus abdominis muscle come from down and from up. What is called inferior epigastric artery and superior epigastric artery. Both of them anastomose here in the middle of the muscle below the rectus sheath. This is exactly the site of the vessels below the muscle. Okay. Sometimes when you are doing lance incision or gridiron incision for appendectomy, and you find like pelvic appendix, and you want to extend the wound to the midline, sometimes you cut or accidentally injure the rectus sheath from outside. You open it sometimes, or open the anterior rectus sheath, or open both anterior rectus sheath and posterior rectus sheath, and injure the muscle. It's very common here to injure the inferior epigastric artery. You find severe bleeding happened because this is a big artery coming from the external iliac artery, the inferior epigastric coming from the external iliac artery before transversing the inguinal ligament. Before crossing the inguinal ligament to be the femoral artery, it is one of the main two branches of the external iliac artery in the pelvis. Okay, and then you have bleeding from this side, and sometimes if you close the abdomen without notice this bleeding, you will have a big anterior wall hematoma, because these fibers transection will inhibit extension of the hematoma, so the hematoma will be localized inside the sheath. What's the other one? Also, you can injure sometimes if you go extension upward, which is called Rutherford extension. Sometimes you injure the other branch of the external iliac, which is the superficial circumflex iliac artery. Superficial circumflex iliac artery. This is the external iliac artery. Before crossing, give one branch up, which is the circumflex iliac artery, and give the inferior epigastric artery. Both of them can be injured during operation. Inguinal canal, very important topic. Before I start inguinal canal, I'll tell you, just imagine what is inguinal canal. Inguinal canal is a canal passing through the three muscles and the fascia transversalis. How it starts? I always say we can imagine the canal as like four curtains. I have one curtain, which is external oblique. I have another curtain, which is the internal oblique. I have a third curtain, which is the transversus abdominis muscle. And lastly, I have the innermost layer, which is the fascia transversalis. Notice that I make the external oblique and the fascia transversalis complete, because what's happening is there is an opening in the external oblique, which is the external or superficial ring, and I have an opening in the fascia transversalis, which is the deep ring or the internal ring. But what happened for the internal oblique and transverse abdomen? They are lifted up. If you have four curtains and you want to pass a stick from backward to front, passing through the four curtains, and I just make a hole in the innermost curtain, and then pass your stick, and then elevate with the stick the second and third layers, and then make another hole in the outermost curtain and pass your stick. So you have two holes in the outermost and innermost layers, and you are rising or lifting the intermediate two layers, which are the internal oblique and the transverse abdominal muscle. What is this arch happened? What we talked about in this is anterior spherical iliac spine. This is the ligament, and this is the pubic tubercle. Remember what I said here? I said this is the inguinal ligament. This is the inguinal ligament, and we said the outer 2/3 gives origin for the internal oblique, and the outer third gives origin for the transverse abdominis. This is the origin of these muscles, and these muscles, reflection of them makes what is called the conjoined tendon, this one and this one. So what happened here is the reflection of these muscles. Reflection of this muscle around the ring will form the conjoined tendon. Both of them will form the conjoined tendon. I just lifted them. And this is our stick. We passed through the two rings. This is the stick. We passed through the two rings in the innermost layer and outermost layer. Okay, so the conjoined tendon makes the roof, or what makes the floor of this? The floor is mainly made by this ligament. This ligament, this is the external oblique come and then reflect around the, make some sort of reflection. So this reflection condensation here will form the inguinal ligament. This one, the inguinal ligament, and then get reflected like this to form the floor of the inguinal canal, like this. This is the external oblique, come and then condense it and then get reflected to form this one. Okay, for like this. This is the muscle. This is the muscle. This is the reflection. And this is our inguinal canal. Okay, so this reflection makes the floor of the inguinal canal. What makes the roof, which is the reflected fibers of the conjoined tendon, makes like this around the canal. This is the canal. Let's do is another color. This is the canal, and this is the reflected. This is the reflected fibers of the two muscles. Okay, it is more wider in the anterior wall, and then when it comes behind the canal, it makes a little bit thinner or a little bit narrower. And this is our canal. This is our canal till the here open in the fascia transversalis. So easily, the roof is mainly from the conjoined tendon, and the floor is mainly from the reflected fibers of the external oblique aponeurosis. Let's read this is canal passage from inside to outside. Length about 1.5 inches or 4 centimeters in adult. By the way, in children, the two rings are almost on top of each other. That's why they don't have oblique inguinal hernia. We said it only in adults because children start to have the two rings almost in front of each other. By age started to be a canal. By age started to be a canal. So this is an infant, child, and then in adult started to be more oblique. So that's why in adult only we say oblique inguinal hernia. In children, we just have the hernia go outside and we do what is called herniotomy. Okay, direction we say this is going downward, medial, forward and medial, and internal ring it is opening in the transversalis fascia. The external ring is an opening in the external oblique. It's very important here, and we'll discuss it again soon, which is what is the site of the internal ring, to do the internal ring test, to differentiate between the oblique and direct inguinal hernia. Internal ring or the deep ring has a surface anatomy of just a little bit or 1 to 2 centimeters above the midpoint of inguinal ligament. Okay, how I can remember this? I'll explain it later. Again, the boundaries, we said the external wall, mainly it's formed by the external oblique and some fibers of the internal and transverse abdominis. As we said, all the external oblique will be forming the whole length of the canal. Okay, and then inside the outer two, this is the inguinal, forming the inguinal ligament. And we said that the outer 2/3, gives origin to the internal oblique, and the inner third gives origin to the outer third gives origin to the transverse abdominis, and that's all of them form the anterior wall of the inguinal canal. The whole length have the external oblique, the outer 2/3 the internal oblique, the outer third is the transverse abdomen. This is all of the canal. Roof, as we said, this is the arching fibers of the internal oblique and transverse abdomen. Posterior wall mainly from the side of the opening. Again, we said the roof is the arched fibers, and then the posterior wall is the wall of the opening, of the internal opening. So the internal opening or the deep ring is open in the fascia transversalis. So it's mainly forming the posterior wall plus the arched fiber of the conjoined tendon. Okay, because as we said, again, we have these fibers from this is inguinal ligament again, and some arched fibers go around the canal. Another color more clear. Arched fibers around the canal from the outer 2/3 to go behind the canal, and then the transverse abdominis takes the outer third only to also be condensed to form part of the canal. So the posterior wall is formed mainly from the fascia transversalis, which all this muscle behind, we have the opening in, okay, plus these arched fibers from the conjoined tendon, from the two muscles of the internal oblique and transverse abdominis muscle. Floor is the arched fibers of the inguinal ligament, arched fiber of the inguinal ligament. Very important here to differentiate between what is the contents of the inguinal canal, and again, I want to remind you what is the contents of the spermatic cord. Okay, the spermatic cord is a content of the inguinal canal, but it also has some contents. Okay, so what is the contents of the inguinal canal? In male, we have spermatic cord plus the ilioinguinal nerve, but in females, we have the round ligament plus the ilioinguinal nerve. Okay, spermatic cord, ilioinguinal nerve, round ligament, ilioinguinal nerve. Just remember that the ilioinguinal nerve is content of the canal, not a content of the cord. This nerve is content of the canal, not content of the cord. Go to the inguinal ligament. I think we have sufficient explanation for the inguinal ligament, how it is formed. This is the arched, lower arched fibers of the external oblique to form the floor of the inguinal canal. Let's differentiate between two important things. Mid-inguinal point and midpoint of inguinal ligament. I like to talk about the midpoint of inguinal ligament. Let's imagine that the inguinal canal has a family. Inguinal canal. This is a family formed by deep ring, superficial ring, and inguinal ligament. So if you want to name or introduce any one of this member, you have to relate it to his family. So if I want to introduce Rami, I have to introduce Rami according to his family. It's called Rami Yusuf. Okay. So I want to know what is the deep ring, what is the surface anatomy of the deep ring. Surface of the deep ring is at a point 1 to 2 centimeters just above the midpoint of the inguinal ligament. Midpoint of the inguinal ligament. What is the superficial ring? It is an opening of the external oblique which forms the inguinal ligament. Very important to know. Midpoint of inguinal ligament, this is one of the family of the internal ring. So don't forget it again. Internal ring is part of the family of the inguinal ligament. So it is just above the midpoint of inguinal ligament. What is the mid-inguinal point? We are talking about the whole place. What is the difference? This is the anterior superior iliac spine, pubic tubercle, symphysis pubis, and then pubic tubercle again. From this point, anterior superior iliac spine to the pubic tubercle, this is the inguinal ligament. But if I did from the anterior superior iliac spine to the midline here in the symphysis pubis, this is the inguinal area. This is the inguinal area. That's why I'm talking this one is the this is inguinal ligament. So midpoint will give me the internal ring just above. But if I am taking the midpoint of the inguinal, mid-inguinal point will be almost here, which is the landmark of the external iliac artery pulsation. External iliac artery or the femoral artery after crossing pulsation. You can pulsate here. You can pulsate here. This is the femoral artery, or you can pulsate here. This is the external iliac artery. So this is the surface landmark of the external iliac artery. External iliac artery is not one of the family of the inguinal canal. So it is related to the mid-inguinal point. It is related to the mid-inguinal point. But the internal ring is one of the family of the inguinal canal. So it is related to the midpoint of inguinal ligament. Again, conjoined tendon, we explained what is formed. This is the lower arched fibers of the internal oblique and transverse abdominis muscle, starting from the outer part of the inguinal ligament to be fused together and inserted in the pubis, pubic crest, and iliopectineal eminence behind the inguinal canal to form a small part of the posterior, what's called, mostly it's about 1/3, medial 1/3 of the posterior wall of the inguinal canal, and it forms mostly the outer 2/3 of the anterior wall of the inguinal canal. So its anterior fibers form anterior, lateral 2/3 of the anterior wall, and its posterior fibers form the medial 1/3 of the posterior wall of the inguinal canal. Very important to know that the nerve supply, remember that I told you that the internal oblique and the transverse abdominis muscle having nerve supply of iliohypogastric and ilioinguinal nerve plus the lower 6 costal nerves. Both of them are unique of having these two fibers. What is the importance of ilioinguinal nerve? Ilioinguinal nerve is very important because it may be injured during appendectomy. It may be injured during hernia operation you are doing, and this is the operation for the external or indirect inguinal hernia. If you can't preserve this nerve and you injure, this is the ilioinguinal nerve, which is a content of the inguinal canal. You have to retract it. When you open, you have to identify and retract it to one side during the operation. If you injure this nerve, you will weaken the conjoined tendon. If the conjoined tendon is weakened, this predisposes to abdominal wall hernia, especially the direct inguinal hernia. So we are doing this for the patient, and indirect inguinal hernia, few months or few years later, from weakness of the conjoined tendon can come to you with a direct inguinal hernia. What is the ligaments most important ligaments of the pelvis or this area of the anterior abdominal wall? Inguinal ligament, from the anterior spherical spine to the pubic tubercle, we talked about. The other one is the pectineal ligament or Cooper's ligament, which is this one, Cooper's ligament. This one, Cooper's ligament or pectineal ligament, through the pectineal line of the pubic bone of the inner ring of the pelvis. And in between, you have a sharp crescenteric ligament called the lacunar ligament, which forms the medial wall of the femoral ring. Forms the medial wall of the femoral ring. So I have three ligaments, one ligament outside, which is the inguinal ligament, one ligament inside, which is the lacunar ligament, and in between they have the crescent-shaped lacunar ligament, which forms the medial lip of the femoral ring. The medial lip of the femoral ring. What is umbilical folds? Very common question in the exam. He asks the umbilical fold and what it represents in the fetal life. Okay. One median umbilical fold, which is urachus of the developing bladder and rectum and pelvis. Okay, which is the urachus. So the midline, we have this one, we have obliterated urachus. What is two medial umbilical ligaments? By the way, this is a laparoscopic view. When you go laparoscopy from the umbilicus, you will find this three folds on the roof of the pelvis and the roof of the abdominal wall, lower part of the abdominal wall. You have two medial folds, which represent the occluded umbilical artery in the fetal life. Occluded umbilical artery, very important to know. The median is the urachus, the remnant of the urachus. The medial are the occluded umbilical arteries, followed by the lateral ones, the lateral umbilical ligaments, which are the elevation fold of the inferior epigastric vessels, which go to the rectus abdominis muscle. This is exactly this one. This is the elevation, which go to makes like elevation fold through the muscle traveling from the external iliac artery to the rectus muscle, make an elevation, which is the lateral umbilical folds. Lateral umbilical folds. What is the Hasselbeck Triangle? Hasselbeck Triangle or Triangle of Halsted. This is the triangle where the direct inguinal hernia happens. What's its importance? This is weakness of the conjoined tendon in this area. Will have direct inguinal hernia goes through this triangle. The direct inguinal hernia always doesn't go through the scrotum. Doesn't go to the scrotum. What is the boundaries of this triangle? Laterally, it is formed by, let's make it a little bit bigger. Laterally, it is formed by the inferior epigastric vessels going to the rectus abdominis muscle. This is coming from the external iliac and go to supply the rectus abdominis muscle. That's why when I do gridiron incision, I may injure this vessel. The medial wall is formed by the rectus abdominis muscle itself, or linea similionaris, and then the floor or the inferior of this triangle is formed by the inguinal ligament. So inguinal ligament, inferior epigastric vessels laterally, and the rectus muscle itself, medial wall of this Hasselbeck triangle. And this is a view from inside If you imagine you have a laparoscopy and you are looking, you will find the Hasselbeck Triangle. Very important here to notice this. This is the inferior epigastric vessels forming the lateral umbilical fold. Lateral umbilical fold. And this is the obliterated umbilical artery forming the medial umbilical fold. And this is Hasselbeck's triangle. This one is the Hasselbeck triangle. You just notice that the medial umbilical fold or the obliterated umbilical artery can divide the Hasselbeck triangle to medial and lateral halves. Medial and lateral halves. Okay, clear? Inferior epigastric vessels, obliterated umbilical artery divides the Hasselbeck triangle into two halves, lateral and medial, and this is an inner view, and this is the lacunar ligament, what we talked about. This is inguinal ligament, and this will be, here should be the pectineal ligament, and that is the lacunar ligament, which is a crescent-shaped structure, crescent-shaped structure with a sharp edge, okay, making the medial lip of the femoral ring. Then go to the spermatic cord. Very important, the spermatic cord. How it is developed, the spermatic cord, the descending testis during embryological development takes folds of the curtain, the four curtains we talked about. Takes folds from the four curtains we talked about, plus part of the peritoneum. So if we imagine that is the developing testis, and then come here and push the peritoneum and all the layers till it reaches the scrotum. So every layer she push and take it a cover from it. So all the muscles of the anterior abdominal wall forming a part of the covering layers of the spermatic cord till it reaches the testes. Most important, very recurrent in the exam. This is very important, this one. In the exam, he asks you, what is the internal spermatic fascia? Let's go from outside. As a tested descent takes part of the external oblique, and when it is go down, it is called the external spermatic fascia from the external oblique. So the first layer outside, the external oblique, forms the external spermatic fascia. The layer behind is the internal oblique. The internal oblique forms the cremasteric muscle and fascia. So the second layer, I'm talking from outside to inside. The second layer dragged by the testis is the internal oblique muscles to form the cremasteric muscle and fascia. The third layer is the transversalis fascia. Transversalis fascia. To form internal spermatic fascia. Internal spermatic fascia. Okay? So very important, these three structures. Okay. Let's go for another thing, which is what is the layers of the scrotum? Layers of the scrotum, very common also in exam and very important as well. Layers of the scrotum. Scrotum from outside to inside. Skin, followed by the dartus muscle. Very important. This is in the subcutaneous tissue. Dartus muscle in the subcutaneous tissue of the scrotum. So skin, dartus muscle, followed by the layers, the three layers we talked about here. which is the external spermatic fascia from the external oblique, cremasteric muscle and fascia from the internal oblique, and the internal spermatic fascia from the fascia transversalis. So the main important two new structures we have to cover this descending testis. We have skin and dartos muscle in the subcutaneous tissue of the scrotum. That's why during the operation of hydrocele in adult and open, he asks you what is the second layer after the skin? Is the dartos muscle. Dartos muscle. What is the contents of the cord? Important. Contents of the cord. Remember, we say it's easy way to say this is we have 3 arteries, 3 nerves, and other 3 structures. This is the easiest way to know the contents of the cord. What is the 3 arteries? We have the testicular artery, we have the cremasteric artery, and we have the artery of the vas. That's why during hernial operation, if you injured or ligated any artery by accident, you will not have ischemia. You will not have a little blood, decreased blood supply to the testis, but it will not affect the testis in a dangerous effect or a serious effect. Will not affect it seriously, as you have a triple blood supply through the cord, which is testicular artery, cremasteric artery, and artery of the vas. What is the 3 nerves? Genital branch of genitofemoral nerve, very important. Genital branch of genitofemoral nerve is content of the inguinal, the spermatic cord, content of the spermatic cord. Differentiate between it and don't confuse between the ilioinguinal nerve, which is one of the contents of the canal. So the ilioinguinal nerve is outside the cord and passing with it through the canal, but the genital branch of genitofemoral nerve is just inside the inguinal, the spermatic cord, just inside the spermatic cord. Plus you have some sympathetic fibers around these arteries, which is the cremasteric artery or artery of the vas and testicular artery. You have some sympathetic fibers for easy remember. What other 3 structure? We have arteries, so we should have impiniform plexus of veins, which is the veins responsible for the varicose veins in adults. Also, we have the vas itself, which is the male reproductive canal, and the obliterated processus vaginalis from the peritoneum. Obliterated processus vaginalis from the peritoneum, which is responsible for the hydrocele, inguinal hernia, and congenital infantile hernia, or infantile hernia and congenital hernia. If it is not obliterated and formed the vestige or the obliterated processus vaginalis, normally it comes like peritoneum go around the testis like this, and then started to be at birth obliterated to form the vestige or a fibrous band. But if it is not obliterated, it will permit contents from the abdomen to go inside, maybe some just abdominal fluids if it is very small, or maybe up to abdominal contents if it is widely happen, to do what is called the infantile hernia or the inguinal hernia in adults. At last, we finish with the abdominal wall with the abdominal dermatomes. I want to mention some important points here, which is asking always about some important dermatomes. Number 1, dermatome of the nipple is T4, level of T4. Number 2, the level of the umbilicus dermatome is T10. Number 3 is the inguinal area is L1. Very important 3 dermatomes you have to know and very recurrent in the exam. Level of the nipple is T. Okay, sorry. So this is the most important 3. T4, T10, and L1. What's asked about L1? He asked if a patient going to do an hernial operation, hernial repair under regional anesthesia. Which region or which level will be anesthetized is the level of L1. Sometimes you will find it T12, sometimes T12, but you will not find in the options T12 and L1 together. Sometimes you anesthetize the region of L1, which is responsible for the iliohypogastric and ilioinguinal nerve, supplying the conjoined tendon and the internal oblique and the transverse abdominis. These are the levels of L1, and this will have be paralyzed to do the operation. In one question, I did think one of the sources of books, I found it T12, but he didn't mention L1, so you can go for T12. But mainly by 95% you will find L1 in this region. The other important thing here, we are talking about planes of the abdomen, planes of the abdomen. And what does it present? We have the midline plane, and then we have the transumbilical plane at the level of L3, L4, L3, L4, just know the levels. Subcostal plane is at the level of L3, subcostal plane at the level of L3. Transpyloric plane at the level of L1. Transpyloric plane is at the level of L1, which is this one. Okay, and this is the most important. We are going to talk about it here. Intertubercular plane at the level of L4, at the level of L4, and this is the level determined to give the spinal anesthesia. We just supracrestal or pubic tubercle supracrestal is a little bit higher, the level of L4, L5, to know or to give the spinal anesthesia. So this is used by doctors of anesthesia to determine the level of L4, L5 to give their spinal needle or spinal anesthesia. And then the mid-clavicular plane, I think we talked about it in the start of the lecture, which one of the planes responsible for dividing the abdomen in 9 regions. What is the transpyloric plane? Transpyloric plane is important to know the structure passing through it. This is the very important L1 surgical significance. It is the end of the spinal cord in adult, but in childs, the end is L3. So end of spinal cord in infants starts from L3, and by adult life, it is at the lower end of L1 or L1, L2. Okay. Also, the transpyloric plane, it's okay, L1. Then go through the structures passing through the transpyloric plane, which is the origin of superior mesenteric artery at the level of L1. Very important. We said before that the 3 main vessels of the abdomen, celiac, superior mesenteric, inferior mesenteric, celiac at the level of C12, superior mesenteric at the level of L1, inferior mesenteric at the level of L3. Origin of the portal vein behind the neck of the pancreas at the level of L1. Neck of pancreas, pylorus of the stomach, second part of the duodenum, sphincter of Oddi, hilum of the kidney, DJ, duodenojejunal junction, ligament of Tretis, fundus of the gallbladder. Very important that the transpyloric plane pass through the fundus of the gallbladder. Sometimes tell you all of the following, one of the following pass through the transpyloric plane, or all of the following pass through the transpyloric plane, except. So you have to know that the fundus of the gallbladder, one of the most important choices that you will have. Tip of 9th costal cartilage, and this is one of the landmarks of the fundus of the gallbladder. Sometimes where is the superficial or the landmark or surface anatomy of the fundus of the gallbladder? It is the meeting of meeting of the linea semilunaris of the rectus abdominis muscle and the tip of ninth costal cartilage. Both of them give you the gallbladder. So the linea semilunaris, or the outer lip of the rectus abdominis muscle, its meeting with the ninth costal cartilage will give you the surface anatomy of the gallbladder. Clear? Okay, now we finish the abdominal wall, and let's start the abdominal viscera and organs. Okay, hello, back again to the abdominal viscera and the abdominal organs. Before I start to talk about the abdominal organs and abdominal viscera, I want to give an introduction, general introduction about how we divide the abdominal organs, especially the GIT tract, which is the main topic of the abdominal anatomy, and an easy way to remember by your mind what is the blood supply and what is the nerve supply for each region, that help you generally to put basic for your study for the abdominal viscera, especially the GIT tract. GIT tract is mainly divided into three parts. First part, which is called the foregut, which is formed starting from the esophagus till the upper half of the second part of the duodenum. And this part takes blood supply from the celiac trunk at the level of T12, and it takes a nerve supply parasympathetic from the vagus nerve and takes sympathetic nerve supply from the greater splanchnic nerve and the celiac ganglia. We always know that in the sympathetic nerve supply, you have a ganglia away from the organ, but this is sympathetic, go for a ganglia, and then go to the target organ. This is parasympathetic. This is parasympathetic. The ganglia will be inside the organ itself. So sympathetic have a ganglia. Sympathetic has a ganglia, which will be here the celiac ganglia, superior mesenteric ganglia, inferior mesenteric ganglia, giving sympathetic nerve supply to the gut. But parasympathetic, the ganglia itself will be inside the organ, or enteric ganglia inside the wall of the GIT itself. It hasn't a relay ganglia outside. Like foregut, we have the vagus nerve supply and going intrinsic ganglia inside the organ itself. The midgut, the same, takes the vagus nerve. The midgut starts from the lower half of the second part of the duodenum till the right 2/3 of the transverse colon, and this takes blood supply from the superior mesenteric artery and takes nerve supply from the superior mesenteric ganglia through the lesser splanchnic nerve as a preganglionic fiber. And the third part is the hindgut, starting from the left third of the colon till the inguinal canal. It takes its blood supply from inferior mesenteric artery. It takes its sympathetic nerve supply from the inferior mesenteric ganglia through the lumbar plexus or the lumbar splanchnic nerve, and it takes parasympathetic supplies through the pelvic splanchnic nerve. So the foregut and midgut takes from the vagus nerve, while the hindgut takes its nerve supply or some parasympathetic supply from the pelvic splanchnic. Arterial supply, celiac trunk, superior mesenteric, inferior mesenteric. Okay, this is broadly about the abdominal divisions or the GIT divisions embryologically. Also, this is which part, every part formed from which organ specifically. Let's start with esophagus. Esophagus starts at this level of C6 as a continuation of the pharynx or oropharynx. Okay. The same level starts the trachea as a continuation of the larynx. Okay, so C6 is a start of end of pharynx and the start of esophagus, and end of larynx and the start of trachea. Keep this number, keep this level of C6 is very important level vertebral landmark. Where is the esophagus ends? The esophagus ends at the level of T10 thoracic vertebra by opening in the diaphragm to join the stomach through the gastroesophageal junction. Three more important, very important opening in the diaphragm you have to know. I have this spinal cord like this, and you have this is the diaphragm. I like to do it like this. So we have three important levels. Level of T12, level of T10, level of T8. T12 is the lowermost one, which represents the aorta. Opening of the aorta at the level of T12. T10 is the level of opening of our esophagus. Level of opening of our esophagus in the diaphragm. Then lastly, T8 is the level of the IVC. Level of IVC. T8 is the level of the inferior vena cava, starting from most posterior at T12, the aorta, T10 in the middle, which is the esophagus, and T8 is the IVC. You can remember with, this is the IVC. So you can remember that the esophagus or the gut is between two vessels, and the esophagus in between at the level of T10. Important structure of the esophagus, you have to know what is the main muscle structure of every part. It is divided on three thirds: upper third, middle third, and lower third. The middle third is the largest third of them. The upper third may be about 5 to 10%. The lower third are the same, and the middle third considers or consists of the biggest part of the esophagus. You have to know that the upper third has striated muscles, but the lower third is a smooth muscle. The middle third is mixed, smooth, and striated muscles. Arterial supply, venous drainage, and lymphatic. The upper third takes blood supply from the inferior thyroid artery together with the thyroid, with the inferior thyroid artery, and has its venous drainage through the inferior thyroid vein. The middle third take branches from the descending aorta, mediastinal vessels, mediastinal branches of the aorta. So it takes branches from the aorta and then go from the mediastinal branches of the azygos as a venous drainage. So it takes blood supply from the aorta, aortic branch, and venous drainage through the azygos branch to the azygos vein. The lower third takes from the left gastric artery from the celiac trunk that supply the lesser curvature of the stomach and wrap around the lower part of the esophagus and supply the esophagus through the left gastric artery and then drains through the left gastric vein as well. Lymphatic drainage of the three parts is a little bit different.
The upper third goes with the neck to the deep cervical lymph node. Again, the middle third, which is the biggest part taking blood supply from the mediastinal vessels, go for the mediastinal lymph nodes as well. And the lower third takes its blood supply from the gastric vessels, so it goes with them to the gastric lymph nodes. Constriction of the stomach, the esophagus. What is the constriction? This is the size of narrowing during you doing an endoscopy. Okay, how you know it? We calculate it as a distance from the incisor teeth. Distance from the incisor teeth. As you go through endoscope, and then it has here levels in centimeters. It is divided in centimeters. You can know which level you are. So you can know this narrowing is pathological or physiological or anatomical, normal anatomical by this one. What is the first narrowing you will meet during your upper endoscopy? You will meet the first one at 15 centimeters from the incisors, which is the pharyngeoesophageal junction. This is the first narrowing you will find in the esophagus, entrance of esophagus or start of esophagus. At the level of C6, we talked about the pharyngeoesophageal junction at the level of 15 centimeters. Very important, very, very important sites for constriction of the esophagus, part A and part B. The second one, which is crossing or arching of the aorta, make an indentation in the esophagus at the level of 22.5 or 22 centimeters. The third one is just below the arching of the aorta, because the aorta arches around the left main bronchus. So below it is the left main bronchus, makes also an indentation. It's about 5 centimeters distal, which is at the level of 27.5 centimeters. The last one is the crossing of the esophagus through the diaphragm at the level of T10. We also talked about, which it will be 40 centimeters, 38 to 40. Sometimes you find it 38 in some books, and sometimes you find it 40 centimeters from the incisor. So the start, the first one is the entrance or the start of the esophagus. The last one is the end of the esophagus. So this is 15 and this is 40, and in between the indentation of the aortic arch and the left main bronchus. What is Zenker's diverticulum? Zenker's diverticulum, very recurrent question in exam and recalls. Where is exactly this diverticulum happen? This is in diverticulum happen in the posterior pharynx and muscles of the pharynx. What is the muscle of the pharynx? The most important one, they have what's called superior and inferior esophageal sphincter. What's important to us to know that the inferior esophageal sphincter or constrictor, it is formed of two muscles. One muscle is called the syropharyngeal muscle, which is the oblique fibers of the inferior constrictor, and the other muscle is the cricopharyngeus muscle, which is the transverse fibers of the inferior constrictor. In between happened the Zenker's diverticulum. Zenker's diverticulum happens in between the two muscles of the inferior esophageal sphincter or the inferior sphincter. What the question come? The question come through or the site of Zenker's diverticulum. It will be through, not inferior, not superior, not above, not below the inferior constrictor muscle. It is through the inferior constrictor muscle or the inferior esophageal sphincter or inferior esophageal constrictor muscle. Syropharyngeus, between the syropharyngeus muscle and the cricopharyngeus muscle, which are both of them are part of the inferior constrictor muscle. Let's go to the stomach. Stomach is the dilated organ of the GIT tract receiving food. It's formed by morphologically from what's called fundus of the stomach, body of the stomach, then pylorus. Body, then pylorus. So fundus, body, pylorus. We have the greater curvature and lesser curvature. We have anterior surface and posterior surface. Okay, muscles or structure histologically, it has a serosa, then the longitudinal muscle layer, the outermost layer, then circular muscle layer, the intermediate layer, and then the oblique muscle layer, the innermost layer, followed by inside is the mucosa of the muscle, mucosa and rouget of the stomach. So longitudinal, circular, oblique, followed by mucosa of the stomach.
Let's go to the arterial supply of the stomach, which is very important. As we said at the start of our lecture, the arterial supply of the stomach mainly comes up till the second part of the duodenum, comes from the celiac trunk. Okay, so celiac trunk let's enlarge this one. This is the celiac trunk. The celiac trunk gives two main branches. First branch to the esophagus gives the left gastric artery, which we said that it gives the lower third of the esophagus together with the left gastric vein. The other big branch of the celiac trunk is the splenic artery, which go to the spleen, and at its end it gives some branches more. It gives branches to the front of the stomach, which is the short gastric vessels, and then give us the left gastrocoploic artery. Epiploic means omental. So this is the greater omentum. So these vessels is called the gastro-omental or gastro-epiploic artery. So give us the left gastro-epiploic artery. This is the second branch of the celiac trunk. The third branch is the common hepatic artery, which is the most important also, and big branch is the common hepatic artery. Common hepatic artery, as a short distance, it is divided into gastroduodenal artery, and then continue as the hepatic proper artery. So gastroduodenal artery, it's very important, passes behind the first part of the duodenum down toward the head of the pancreas, and then give another branches which goes up and laterally, which is a common hepatic artery, which it divides on the left to the left and right hepatic artery, and from the right hepatic artery we have the cystic artery. So the cystic artery comes from the right hepatic artery, from the proper hepatic artery. Important vessel comes from the hepatic proper artery, which is the right gastric artery. This one, right gastric artery. The right gastric artery anastomoses with the left gastric artery on the lesser curvature of the stomach to supply the distal part of the lesser curvature of the stomach. What's another important? This is, by the way, this is the gastroduodenal artery. Okay, that passes behind. This is the gastroduodenal artery, passes behind the first part of the duodenum, and then which divides into branches again. This is the omentum, so it will give us the right gastroepiploic or right gastroomental artery,
and give us the superior pancreatico-duodenal artery. Superior pancreatico-duodenal artery, which supplies the duodenum and the head of pancreas. The duodenum and the head of pancreas. Okay, this is briefly the branches of celiac trunk: left gastric, splenic, hepatic, common hepatic. Splenic will give us short gastric and gastroepiploic, left gastroepiploic. The common hepatic will give us gastroduodenal, common hepatic, or sorry, proper hepatic artery. Proper hepatic will divide into right and left branches, and the right branch will give us the cystic artery for the cystic duct, and then proper hepatic will give another branch important with the right gastric artery. Again, back to the gastroduodenal artery, which will give us the right gastroepiploic and superior pancreatico-duodenal artery. Very important surgical importance of this artery behind the first part of the duodenum, which is the most common part for duodenal ulcer. That's why in perforated duodenal ulcer with bleeding, the artery responsible for this bleeding is the gastroduodenal artery, as it passes at the posterior wall of the first part of the duodenum. And this is an emergency, should be ligated, should be undermining the artery. What will you do for this artery if you have bleeding from the artery? If you have bleeding, so you have to undermine the ulcer of this artery.
Again, venous drainage of the stomach. Venous drainage of the stomach also is very important. Every artery will go to its corresponding artery. So the left gastric and the right gastric will go through the left gastric vein and the right gastric vein, which will drain directly to the portal vein. By the way, the portal vein is the main venous drainage of the stomach. Portal vein is the main venous drainage of the stomach, whatever directly or indirectly through its two branches. So left gastric artery gives the left gastric vein, right gastric artery, right gastric vein. Both of the right and left gastric veins go to the direct to the portal vein. Then we have the right and left gastroepiploic arteries. The right gastroepiploic artery, which will go with the splenic to superior mesenteric vein. So the right gastroepiploic artery vein will go to the superior mesenteric vein. The left one will go to the splenic vein, and both of them unite behind the neck of the pancreas to form the portal vein. So the portal vein is formed by superior mesenteric, splenic, unit behind the neck of the pancreas at the level of L1 to form the portal vein. The right gastroepiploic drain into the superior mesenteric, the left gastroepiploic drain into the splenic, so they indirectly drain to the portal vein. But the right and left gastric directly drain into the portal vein. Nerve supply, as we agreed, nerve supply sympathetic through the celiac plexus and the greater splanchnic nerve, and parasympathetic through the vagus nerve. We have in the stomach what is called anterior vagus and posterior vagus. So how I'm confused, I have what is called right vagus and left vagus. The rotation of the gut happens from left to right rotation, like this one. So here is the left gastric and here is the right gastric. When the gut is rotated in this direction, the left gastric became the anterior vagus and the right gastric becomes the posterior vagus. So the left vagus becomes the anterior vagus of the stomach. This one is mainly the left vagus nerve coming through the chest, through the thorax, and the posterior vagus is mainly the right vagus coming through the thorax. Not to confuse between anterior, posterior, and left and right. The left becomes the anterior, the right becomes the posterior. The anterior will give nerve supply to the liver and gives the anterior nerve of letter jet. The posterior will give branches to the celiac branch, to the celiac artery, and also gives the posterior nerve of letter jet. Posterior nerve of letter jet. Lymphatic drainage. Lymphatic drainage of the stomach. Regional lymphatics, we can divide the stomach into like 4 areas. Superior gastric group of lymph nodes. Suprapyloric group of lymph nodes. Infrapyloric group of lymph nodes. Pancreatico-linear group of lymph nodes. This is short gastric vessels and forming the gastric ligament or the gastrolinear ligament or the gastrosplenic ligament. So it gives lymph nodes to the pancreatico-linear lymph nodes. The lower part of the greater curvature go to the inferior pyloric lymph nodes. The upper part of the lesser curvature and the fundus and the gastroesophageal junction go to the superior gastric lymph nodes or the superior gastric vessels, and then the distal part of the lesser curvature go to the suprapyloric lymph nodes. So easy, it is named according to its region. What is the ligaments attached to the stomach? The stomach has 4 main ligaments, but most important is from the lesser curvature, we have what's called the lesser omentum, which go to the liver, lesser omentum, go to the liver, this one, which is called the gastrohepatic ligament, and we know it as a lesser omentum. The other one is comes from the greater curvature to the transverse colon, which we call, but just after wrapping like this, which we call the gastrocolic ligament or greater omentum, gastrocolic ligament of or greater omentum. This is the second name. Another 2 small ligaments, one go to the diaphragm, gastrophrenic ligament to just stabilize the stomach, and the other one through which the short gastric vessels pass, which is between the stomach and the spleen, which is the gastrosplenic ligament, and through which the splenic artery give the short gastric vessels which supply the fundus of the stomach. And this is the first ligament we divide and incise to reach the hilum of the spleen during splenectomy. Again, this is the spleen, this is the stomach. Okay, we have one ligament here, through which the short gastric vessels go, and to this we have to incise to reflect the stomach laterally, and we can see the hilum of the pancreas, to start doing completion of splenectomy. So the first one, this cut, and this has highest risk of injury to the fundus of the stomach. So ask you during emergency splenectomy, what is the most common, if you are cutting the gastrosplenic ligament, what is the most common organ to injure? The fundus of the stomach. We have another ligament important, we will talk about it later. So this is the four: lesser omentum, greater omentum, or gastrocolic, or hena gastrohepatic, gastrophrenic, and the gastrosplenic ligament. This is the main four ligaments of the stomach. Relations of the stomach, just reading. Most important that is behind the stomach is the lesser sac. Lesser sac is behind the stomach. Lesser sac is a posterior relation to the stomach. What is the lesser sac? As we said here, let's make it a little bit larger. Okay. This one is the gastrohepatic ligament, and it has a free border, and you can put your finger here. You can put your finger here, which is the epiploic foramen, and this is the entrance of the lesser sac. What is the insert? Let's us, like we cut the greater omentum to reflect the stomach. So we will find this picture. This is the lesser sac. This is the lesser sac we find. Okay. What is the importance here? Very important. In the free margin of the lesser omentum, we have three main structure passing. In the free margin, we have three main structure passing. Okay. We have from the celiac trunk, we have the iliac artery, hepatic artery. We have the portal vein, and we have the common bile duct. Three main structures passing here in order. The hepatic artery to the anterior and to the left, the common bile duct anterior and to the right, and then behind is the portal vein just behind. This is in order. And this free border or free margin of the lesser omentum, what we use to do Pringles maneuver. We just compress between two fingers to stop any hepatic bleeding after trauma or any other cause, like during cholecystectomy, and you have a bleeding from the cystic artery. By compressing this this free border or free ligament, free margin of the lesser omentum by your fingers or by a vascular clamp, you can stop bleeding temporarily from the liver until you do your repair. Duodenum. Duodenum is the continuation of the pylorus of the stomach. It is a C-shaped structure, and inside is the head of pancreas. It is formed of four parts mainly. First part, second part, third part, fourth part. As we said, that the second part is the division between the foregut, and it is upper part is the foregut, and the lower part is hindgut, is midgut. We also want to know that the duodenum level is between L1 and L3 level. So the first part is at the level of L1, the third part cross the level of L3. Remember that L1 is the transpyloric plane. So the duodenum started at the transpyloric plane L1. Okay. relations and structure of each part. What's most important to us? We just write the first and second and third and fourth part for you to understand like a continuous story. But what's more important to us is second part and third part. Relations, you have to know relations and course and any surgical importance of the second part and third part. The first part, we have the most important thing. This is the most common part for the gastro-duodenal or the duodenal ulcer. And if perforation of the duodenal ulcer happened here, you will have an emergency bleeding. And severe bleeding can lead to death. And this is an emergency situation for upper endoscopy to undermine or to clip the bleeding area to occlude the gastroduodenal artery, which is responsible from bleeding from the first part of the duodenum. Okay, this is the most important part about the first part of the duodenum. What structure pass behind the first part? We said it just a few minutes ago, which is the three main structures, which is the hepatic artery, anterior, and to the left, the bile duct, common bile duct, anterior, and to the right, and then the portal vein just posterior. And these three structures forming the free margin or the free border of the lesser omentum. And this is the part we occlude by finger. You just put your finger here and occlude to stop any bleeding from the liver, or put a vascular clamp till you repair or manage your patient. Second part of the duodenum, that part is important. That part is important. And the most important is the relation. It's vertical part, okay? And it, as we said, the upper part is foregut, the lower part is midgut. It is the part of opening of the bile duct, common bile duct, okay? The part of the opening of the duodenal papillae, which opens at posteromedial wall, opens at the posteromedial wall. We mentioned it in the common bile duct with the biliary tract and the pancreas. The second part is very important because it's the opening of the common bile duct with the pancreatic duct with the ampulla of water. Just till it comes, you have this second part, posteromedial wall, opening of the ampulla of water, which is the common between the common bile duct and the pancreatic duct, at a 10 centimeter distal to the pylorus. 10 centimeter distal to the pylorus at the posteromedial wall of the second part of the duodenum. Very important landmark. Also, the relations are very important, especially the posterior relations. It has hilum of the kidney and part of the kidney, the right edge of the IVC, also the right psoas major muscle. So the hilum of the kidney, right kidney, and hilum of the kidney with the renal vessels, inferior vena cava, right edge of it, and the right psoas major muscle. Anterior relations, as we said, the gallbladder, right lobe of the liver, transverse colon and transverse mesocolon, and the coils of the colon is part of the anterior wall, but the most important is the posterior wall. And we know that is medially, it encircles the head of pancreas medially. So the head of pancreas is a medial relation to the second part. Lateral relations is also the liver and the colic flexure. Liver and colic flexure is just lateral to it, but most important is the posterior and anterior, but the posterior is the most important structure. Third part is also very, very, very important, and this is the most important one in the parts of the duodenum, and it's frequently asked in the exam. Anterior relations and posterior relations. You have to know it by heart. Anterior relations, by the way, it is passes through L3 vertebrae at the level of L3 vertebrae. Okay, and this is the site of origin of inferior mesenteric artery, but the inferior mesenteric artery just below it, okay, behind it. But above it, at the level of L1, origin of the superior mesenteric artery. And then superior mesenteric artery and vein comes in front of the third part, and in front of the ANCUS process of the pancreas. So it is originate from L1 and then go between the neck and ANCUS, and then cross in front of the ANCUS and cross in front of the third part of the duodenum. Also, what is in front of the third part of the duodenum? Root of mesentery. Root of mesentery of the small intestine. It is just in front of the third part of the duodenum. What is behind? Posterior. All this structure crossing. IVC, aorta, and all the right structures. Keep that mostly all right structures. Right psoas major, right ureter, and right gonadal vessels. Because it's coming from right to left, so it crosses all the right psoas major, right ureter, right gonadal vessels, then pass to go through the IVC and the aorta. Okay. Let's move to the fourth part of the duodenum, and it is not so important to us. And no question, just we have this, but this is the last part of the duodenum, which joins the jejunum at the DJ at the level of L1, at the DJ at the level of L1 to form the duodenal-jejunal junction. What is inside the duodenum? That's what we explained few minutes ago. Major duodenal papillary, very important MCQ, posteromedial wall of the second part of the duodenum from 8 to 10 centimeters distal to the pylorus. That's the most important. The duodenal papilla, which is the open the ampulla of water, which is the common duct or the common canal between the pancreatic duct, the main pancreatic duct, and the main common bile duct. Suspensory muscle of the duodenum or the ligament of Tretis. This is the ligament of the DJ or the duodenal-jejunal flexure. It's called the ligament of Tretis. Blood supply, innervation, and lymphatic drainage of the duodenum. Most important is the blood supply. It takes blood supply from two branches because, as we said, it is upper and lower parts, foregut and midgut. So it takes from the celiac and it takes from the superior mesenteric artery. Both arteries are with the same name. So it takes superior pancreaticoduodenal artery from the celiac trunk, and it takes inferior pancreaticoduodenal artery from the superior mesenteric, and both of them has anterior branch and posterior branch to supply the anterior wall and the posterior wall of the duodenum and head of pancreas as well, and venous drainage is through the corresponding veins. Also, it takes its parasympathetic supply through the vagus nerve. As we said, that the foregut and the midgut, both of them take the vagus nerve, and it has a lymphatic drainage to the gastroduodenal group and the pancreatico-duodenal and the hepatic groups of lymph nodes, and then at last gives to the celiac or the superior mesenteric lymph node as an end lymphatic drainage, according to which part have the problem. But mainly the gastroduodenal and pancreatico-duodenal lymph nodes are the main lymphatic drainage of the duodenum. Small intestine. Small intestine is enclosed through a very big mesentery called mesentery of the small intestine. The mesentery of a small intestine starting from the DJ, as we explained before. This is the root of mesentery, like you are holding a fan between your hands. You have a root for this fan, and you then spread this fan to form the 6 meters of the small intestine. The root itself is 6 inches, and the spread or the free border of this mesentery is 6 meters. So free border 6 meters, root 6 inches. The most important is the structures. The root crossing starts from left to right structure. It crosses through the fourth and third part of the duodenum, crossing the aorta, passing through the IVC, then the right psoas muscle and the right ureter. Very important, a relation, posterior relation of the root of the mesentery, even during operation, interoperative. Fourth part, third part, just imagine them by this order from left to right. Fourth part, fifth part, aorta, IVC, then go to the right psoas muscle and the right ureter as well. What is the contents of the root of the mesentery? The contents of the root of the mesentery. The free border contains the cold of the jejunum and the ileum. The jejunum is about 2/5, and the ileum is 3/5 of the whole small intestine. Superior mesenteric vessels are very important. Where can you find during operation? Where can you find during operation? Is you go just follow the mesentery of the small intestine to reach the root, and at the bottom of the root, you will find the superior mesenteric artery and vein, also plus some lymphatics and lymph nodes of the superior mesenteric artery. Jejunum and ileum, as we said, this is 2/3 and this is 3/3. The jejunum has a larger circumference related to the ileum, and it has also a less fatty mesentery. That's why you can see in the jejunum, you can easily see the vessels through the mesentery, but in the ileum it is more fatty, so it is just you need illumination to see the vessels. Also the vasa recta, which is the small branch going to the small intestine. It is long and few in the jejunum, but it is short and numerous in the ileum. Short and numerous in the ileum. Large intestine is formed by continuation after the ileocecal valve, cecum ascending, hepatic flexure, transverse colon and mesocolon, splenic flexure, descending colon, sigmoid, then rectum, then the anal canal and anus. This is the part of the large intestine. What is characteristic inside the operation? You will find hostration. It's an inverted U shape, and you'll find this is big hostrations, which is characteristic for the large intestine. Cause of this hostration is the tinea as the tinea coli is shorter. This is the tinea coli. This is condensation of the longitudinal muscle layer into 3 bands, forming the tinea coli. And this is shorter than the length of the colon itself. So it's, when condensed, it makes this, when condensed, it formed these hostrations like festoons, like you're having a short muscle and you just pull it. So a long piece of any towel or something like this, so makes what is called like festoons. What's characteristic also is appendices epiploica, which is more on the left side, and plus the tinea coli. All the colon has tinea coli except for the appendix and the rectum. So the external or the longitudinal muscle layer of the colon is condensed in 3 layers throughout the whole colon, except of the rectum and the appendix. It makes the whole circumference of the gut, makes the whole circumference of these parts. What is the peritoneal covering? The ascending and descending parts have a peritoneal covering from front and from the sides. The transverse mesocolon completely intraperitoneal and have its transverse mesocolon. The sigmoid colon also completely intraperitoneal and has its sigmoid mesocolon. Sigmoid mesocolon. Cecum, it is the first part of the large intestine. What's its importance? It has the opening of the appendix and also the opening of the ileocecal valve or ileocecal junction on the posterior or posteromedial wall as well. The same like the second part of the duodenum, posteromedial wall. Posteromedial wall is the opening of the ileocecal valve. The 3 tinea coli here meet at the base of the appendix to form a continuous layer around the appendix. Blood supply, ileocolic artery from the superior mesenteric artery. We agree that the superior mesenteric artery gives the whole small intestine, the large intestine ascending, and hepatic flexure, and right 2/3 of the transverse colon. Appendix, it is in the right iliac fossa, also in the posteromedial aspect of the cecum. So most structures now are posteromedial aspect of the cecum, and the 3 tinea coli condensed around to form the whole layer of the wall of the appendix. What is the positions of the appendix? Very important question in recalls. Most common is the retrocecal, which represents about 74%, and the least one is post-ilial, which is less than 0.5%. So the most common site of the appendix surgically is the retrocecal appendix. Peritoneal cover, the appendix is completely covered with its mesoappendix, which is ligated during appendectomy. Also, it has a nerves arterial supply from the appendicular artery, from the ileocolic artery of the superior mesenteric artery. Take care, this is an end artery. That's why when inflammation happened in the stomach, in the appendix, it is rapidly progressive because it causes a rapid deterioration of the condition because it is thromposed, and so the blood supply to the appendix is affected. The rectum, the second most important part in our large intestine. Very important, everything to know about the rectum. It starts in the pelvis. It is a pelvic organ. starts from as a continuation of the sigmoid colon at the lower half of this sacrum, and ends at the level of anal canal or anorectal junction, which is the puborectalis muscle, is a landmark from between the rectum and the anal canal. Puborectalis muscle, which is the muscle you will feel at the posterolateral aspects during PR or digital rectal examination. You will find a muscular structure making like stenosis, or making, sorry, like a constriction, grasping on your finger, which is the puborectalis muscle. This is the puborectalis muscle you will feel by digital rectal examination on the posterolateral walls or lateral walls of the anal canal during digital rectal examination. Peritoneal covering of the rectum is very important. It is in 3 parts. The upper part is covered like the ascending and descending column from front and sides. The middle part is only covered from the front, and then the peritoneum is reflected, and the lower part above the bladder or above the uterus, and the lower part is completely extra peritoneal, no peritoneal covering. What is anterior relations? Most important in males, we have the rectovesical pouch, and in females we have the Douglas pouch, like we say here, the Douglas pouch, or the the rectouterine pouch, and here rectovesical pouch. We have in female another part, which is the vesicouterine pouch in front. Don't confuse between rectovaginal pouch, which is the Douglas pouch, rectovaginal or rectouterine pouch, which is the Douglas pouch, and the utero-vesical pouch anteriorly. In male, we have only one, which is the rectovesical pouch. Very important 2 structures here is the Dunini-Vels fascia and the Waldeyer fascia. The Dunini-Vels fascia is the fascia between the rectum and the urinary bladder and prostate. Okay, between the rectum anteriorly and the urinary bladder and prostate, and this delays the spread of cancer between them. Whatever the cancer in the prostate is delayed by this fascia, or tumor in the rectum, delayed spreading, direct spreading by this fascia, delays the spread of direct spread of any cancer. The other one is the Waldeyer's fascia, which is posterior to the rectum, and it is between the rectum and sacrum. Waldeyer's fascia between the rectum and sacrum, very important, both of them in questions and MCQ. Where is the site of this fascia? Blood supply to the rectum is very important, because one of the sites of portosystemic anastomosis. One of the sites of portosystemic anastomosis is the rectum. The rectum has 3 branches from 2 different arteries. The superior rectal artery and vein, this coming from the portal circulation from the superior mesenteric artery, gives as superior rectal artery as an end branch, and superior rectal vein follows the portal circulation, and then has 2 other branches, which is the middle rectal and inferior rectal, both of them from the internal iliac artery. Middle rectal direct from the internal iliac artery, and this is systemic branch. Inferior rectal artery is from the internal pudendal artery, which is a branch from the internal iliac artery. So it is systemic also as well, so doing the portosystemic anastomosis. So anastomosis between the superior rectal vein and the middle and the inferior rectal veins makes what is called the portosystemic anastomosis. Anal canal. Anal canal is started 1 inch below the coccyx Forget about this. This is about 4 centimeter in length, and this is also the length of the internal sphincter of the inner canal. The inner canal has 2 main sphincter. One involuntary, which is the internal sphincter, which is formed of smooth muscles. Smooth muscle, and it surrounds 3/4, the upper 3/4 of the anal canal. And it has an autonomic nerve supply. So it is involuntary, smooth muscle, autonomic nerve supply. The external sphincter is voluntary and formed of striated muscles. We have, this is the external sphincter, and this is the internal sphincter. The internal sphincter here surrounds upper 3/4 of the anal canal, and it is smooth muscle involuntary. The external inner sphincter formed mainly of 3 muscles: subcutaneous, superficial, deep, and these 3 muscles form the external inner sphincter, which is voluntary striated muscles. You can control yourself. Nerve supply of this voluntary is somatic nerve. Somatic nerve is from the pudendal nerve. Somatic from the pudendal nerve. What is the surgical importance of the internal sphincter? This is the sphincter. We do sphincterotomy during any painful anal condition like anal fissure or any operation, spastic condition of the anus. During the operation, we do what's called lateral sphincterotomy. We cut about 1 to 1.5 centimeter or 2 centimeters according from this muscle to relieve the spasm. Anorectal ring is formed mainly from all this structure. This is the anorectal ring, formed mainly from the whole internal sphincter of the smooth muscle, the deep part only of the 3 parts of the external anal sphincter, and the puborectalis muscle. Puborectalis muscle posterolaterally during digital rectal examination. Very important question in MCQ. So internal sphincter, deep external sphincter, and the puborectalis muscle forms the anorectal ring. Surgical importance of the anorectal ring, very important question also in MCQ. If it is injured or if it is lost or rectified or it is damaged, it results in incontinence. Inner mucosa. The inner mucosa is formed from what is called anal columns or columns of Morgagni, and what is called the dentate line. The anal mucosa or columns of Morgagni has what is called mucosal folds or anal valves separated by grooves. Like we say here, this is the valves. Like we see here, the valves and the grooves through the longitudinal anal columns or columns of Morgagni. These columns through which the rectal veins run and rectal vessels run through these folds. We have also what's called the pectinate line or the dentate line. Very important, the dentate line that differentiate between the end of the 2 embryological different structures. What is the difference between the anal canal above the dentate line and below the dentate line is here. You just want to know that above the dentate line, it is endodermal in origin, but below the dentate line, it is ectodermal in origin, like skin and stratified squamous epithelium. That's why the lining epithelium in the above the dentate line is simple columnar epithelium, the same like the other parts of the gut, but in the below the dentate line, it is skin formed by stratified squamous epithelium, nerve supply autonomic, but here it is sensory. That's why painful anal conditions happens from this part. Blood supply, as we said before, superior rectal vessels, which is portals in circulation. Here is the middle and the inferior rectal vessels from the internal iliac artery. This is systemic circulation. Lymphatic drainage is very important. Lymphatic drainage is very important. The upper part or the above the dentate line, it goes to the internal iliac lymph nodes, while the superficial part, which is the most common site for anal cancer, go to the inguinal, superficial inguinal lymph nodes. So in patient having superficial inguinal lymph node palpable, you have to examine the anus. It may be a site of cancer or maybe inflammation, any infection or inflammation or anal abscess or perianal abscess gives palpable lymph nodes around the superficial inguinal lymph nodes, superficial inguinal lymph nodes. As we said, columns of Morgagni will be absent below the dentate line. Ischiorectal fossa is also a place of very common abscess formation. Abscess formation, ischiorectal abscess. We just need to know the boundaries of the ischiorectal fossa. Very important just to know about the boundaries. The base is formed from the skin and perineum, and this is where we do the incision to evacuate the ischiorectal abscess. The medial wall is formed mainly from the anal canal, the medial wall, and the lateral wall is formed by the obturator internus muscle, and this is the floor is formed from the skin. We do incision here to evacuate the ischiorectal fossa abscess. We incise this part to evacuate the abscess. What is the contents of the ischiorectal fossa? It has some fat, pudendal or alcox canal, and inferior rectal nerve and vessels. Inferior rectal nerve and vessels, very important, this canal, which is the alcox canal, pudendal canal or alcox canal, which have the pudendal nerve S234, which is responsible for the somatic and a voluntary supply of the external anal sphincter, which if injured or damaged will cause incontinence. Also, the internal pudendal vessels as well. So the alcox or pudendal canal has two contents. Pudendal nerve S234 keeps poo out of the floor, to remember. S234, pudendal keeps poo out of the floor, and also it supplies the external voluntary sphincter of the urethra, which will keeps also pee out of the floor. It will keeps poo and pee out of the floor. Blood supply. We give an introduction about the blood supply of the gut, mainly from the celiac trunk, and we talk about it in details. Superior mesenteric artery at the level of L1 vertebrae, and it gives blood supply to starting from the lower half of the second part of the duodenum, and gives the whole small intestine, ascending cecum, ascending colon, and the right 2/3 of the colon, transverse colon, and then gives branches iliocolic artery, right colic artery, and middle colic artery. Iliocolic, right colic, and middle colic artery, and these arteries are very important in doing resection anastomosis or in colectomy, because you remove every part with its blood supply. So transverse colectomy will remove the middle colic, right hemicolectomy removes the right, the iliocolic,
and the right colic artery, and so on. The inferior mesenteric artery is the branch at the level of L3. Okay, and this branch gives the left colic artery, which gives the left third of the transverse colon with the splenic flexure descending colon, and you have the sigmoid arteries, which gives the, this is the left colic, this is sigmoid arteries, which gives the sigmoid colon, and ends by being the superior rectal artery. Superior rectal artery supplying one of the three branches of the supplying the rectum, superior rectal artery. Venous drainage, mainly the GIT is drained through the portal circulation, and as we talked about, portal circulation is mainly formed by splenic artery, splenic vein, superior mesenteric vein joined together behind the neck of the pancreas at the level of L1 to form the portal vein. The inferior mesenteric vein drains into the splenic vein. Superior mesenteric vein drains into the splenic vein. This is the portal circulation, and every vein takes the same like the blood supply of its region. What is the portosystemic anastomosis? Very important, part A and part B as well. We have 6 main places for portosystemic anastomosis. What is the most important? The most important is the esophagus, anal canal, and umbilicus. This is the most 3 important places you can examine or having manifestation and surgical importance in portal hypertension. The first one is the lower esophagus. It will have anastomosis between systemic and portal circulation. Portal circulation, we talked about left gastric veins and left gastric artery, which is left gastric vein, which will anastomose with the azygous veins. Azygous veins. We said that the azygous veins drains the middle third of the esophagus, and the left gastric vein drains the lower third of the esophagus. Post anastomosis here is an anastomosis between portosystemic circulation, which is a common site of esophageal varices. Esophageal varices. Anal canal. We say the superior rectal vein is a portal circulation, and we say that the middle and the inferior rectal veins are systemic circulation from the internal, passing through the internal iliac vein. This is a site of portosystemic anastomosis and anal Cushing or anal varices. The third important part is the umbilicus. Umbilicus has portal circulation from veins of the ligamentum teres. Veins of the ligamentum teres going to the liver, and systemic from the superior and inferior epigastric veins. We said that the rectus sheath has, rectus muscle has blood supply from the superior rectal vein, superior rectal artery, and superior and inferior superior epigastric artery and the inferior epigastric artery, and they drain through the superior and the inferior epigastric veins, which has an anastomosis with branches of the veins of the ligamentum teres. Veins of the ligamentum teres passing through the falciform ligament makes an anastomosis of portosystemic circulation. Other non-important or have a little surgical importance and significance, bare area of the liver, which have hepatic and portal veins as a portal, and inferior phrenic vein as a systemic branch. Patent ductus venosus is very rare also. Left branch of portal vein
together with the inferior vena cava as a systemic circulation. The other is the retroperitoneal structure, which is colonic veins, and all the colon we said that is a portal circulation, and some posterior abdominal wall veins or body wall veins, which are systemic, and these are very rare, and even in exam are very rare as well. So this is the most three important you have to keep in your mind. Abdominal organs. Let's start the abdominal organs. We'll go through the liver, the biliary system, the pancreas, the spleen, and so on. Let's start with the liver. The liver has mainly is the right hypochondrial space. The liver has two main divisions or two classifications in dividing the liver. One is called surgical or functional loops, and another called anatomical loops. Anatomical or morphological, what you see in front of your eyes, but surgically they have different opinion in it. It is divided by what is called Cantel's line to right and left surgical loops. Right and left surgical loops. The surgical loops, this Cantel line passing through the fundus of the gallbladder and the IVC. This is a groove of the IVC till the groove of the fundus of the bladder divides the liver surgically or functionally to right and left loops. Then it is further divided in 4 sectors and 8 segments. 4 sectors and 8 segments, not so important to us. What is the importance of this surgical or functional loop? Why we divide it into surgical and functional? Surgical because during every segment of this part and division of the surgical divisions has its own arterial, portal, and hepatic duct supply, and can be resected completely without damage of other sectors. So you like doing complete resection of this part with its private bundle of arterial and venous and duct supply. This is surgical classification. This is an inferior view showing the surgical. This is the line, Cantel's line. This is the Cantel's line between the gallbladder bed and the groove for IVC. But morphologically, we know that the liver has a right lobe and left lobe, which is divided by the falciform ligament from front, anterior, and superior surface, and then ligament for ligamentum teres on the inferior surface of the liver, and groove for the ligamentum venosum at the posterior or post-superior surface. Ligamentum venosum, ligamentum teres, and from front we have the falciform ligament. Gives us the left lobe and right lobe, and this is morphological classification. Morphological classification. We have another thing which is a caudate and the quadrate lobe. Very important exam asking about the boundaries of each one of these loops. Where is the caudate loop? The caudate loop is this part. The caudate loop is this part on the posterior surface, just between the IVC and the porta hepatis. Between the IVC and porta hepatis and the ligamentum venosum, and it has what is called the caudate process. Caudate process, which forms the roof of the epiploic foramen. Epiploic foramen. So, caudate loop, we have from the right is the IVC, from the left is the groove for ligamentum venosum, Up is the upper border of the liver, below is the porta hepatis. What is the quadrate loop? The quadrate loop is this quadrant besides the gallbladder. This quadrant besides the gallbladder. It has the gallbladder on the right, the groove for ligamentum teres on the left. Below it is the free lower border of the liver, and above is the porta hepatis. This is the quadrate loop of the liver. Gallbladder on the right, ligamentum venosus. This is, by the way, this is a back view for the liver. Back view of the liver. So this is the groove for ligamentum teres and free border of the liver from below, and porta hepatis from above, and this is inside is the quadrate loop. This is, maybe we can imagine this is the quadrate loop from front. Gallbladder on the right, ligamentum teres on the left. Behind here you will find the porta hepatis and the free margin of the liver from below. Again, a nice picture for the quadrate loop. Quadrate loop and the caudate loop as well. Caudate loop as well. Peritoneal covering. The liver is completely covered by peritoneal except of the bare area of the liver, which is this area. Bare area of the liver, which is area at the dome of the liver just below the diaphragm. And also the sites of grooves for organs inside the liver, which is a groove for IVC and porta hepatis and fossa of gallbladder. This is considered extra or retroperitoneal areas. But the most important is the bare area of the liver. Bare area of the liver, this one. What is the peritoneal foldings of the liver? The liver have many peritoneal folds. Most important is the falciform ligament to the anterior abdominal wall. Starts from the anterior surface of the liver between the right and left anatomical loops, and then go to the diaphragm, up to the diaphragm, and anterior to the anterior abdominal wall. This is supports the liver. The other one is the free border of the falciform ligament, which is the lesser, the ligamentum teres, lesser omentum between the stomach and first part of the duodenum and the liver. Lesser omentum, one of the ligaments of the liver and peritoneal folds of the liver. The other two is the triangular ligament, right and left triangular ligament, this one. Like you are holding the liver between two, from the two terminal sides of the liver, forms the right and left triangular ligaments with the diaphragm. It holds the liver with the diaphragm. And at last, the upper and lower coronary ligaments, which is here, inferior or lower coronary ligaments, and superior or upper coronary ligaments, also with the diaphragm. So with the diaphragm, falciform ligaments give part to the diaphragm, right and left triangular give parts to the diaphragm, superior and inferior coronary ligaments give parts to the diaphragm. Blood supply to the liver is mainly from the portal vein, giving 70% of the blood supply, and then the hepatic artery gives about 30%. By the way, this is amount or morphologically, anatomically, portal vein gives 70% and hepatic artery gives 30%, but oxygen supply to the liver is 50% from the portal and 50% from the hepatic artery. Both of them give the same arterial supply because the portal vein has a little oxygen than the hepatic artery, and still the hepatic artery supplying only 30% of the blood, but it gives more than 50% of the oxygen supply to the liver. Venous drainage through the 3 hepatic veins, which open in the IVC before it entrance of the diaphragm at the level of T8. At the level of T8 to open in the right atrium, of the heart. So it drains in the IVC, open in the diaphragm to drain in the right atrium of the heart through the diaphragm at the level of T8. Gallbladder, also very important to know the gallbladder. What is the surface anatomy of the gallbladder? Fundus of gallbladder, we told before, this is a junction between the border of the rectus muscle and its meeting with the tip of 9th costal cartilage. This is the area of the gallbladder, fundus, surface anatomy. Blood supply to the gallbladder through the cystic artery, which passes through the callus of triangle, and the cystic vein. And the cystic artery comes from the right hepatic artery. Cystic artery is a branch of the right hepatic artery to the gallbladder, and the cystic vein go to the right branch of the portal vein. Lymphatic drainage through the cystic lymph node of Lund, which is also inside the callus triangle, cystic lymph node of Lund, and from it directly to the celiac lymph node around the celiac trunk, because it takes a blood supply from the celiac trunk. So it gives nerve supply to the celiac lymph nodes, but it passes first through the cystic lymph node of Lund, which is one of the landmarks of the callus triangle, and just beside the cystic artery. What is the callus triangle? This triangle of safety during cholecystectomy. What is the boundaries? Liver from above, cystic duct and gallbladder from the right, and common hepatic duct from the left. This is the boundaries of the callus triangle, and this is the triangle of safety for cholecystectomy. What is the contents? It contains the cystic artery and its lymph node, which is called lymph node of Lund. Nerve supply. As you said, the liver takes parasympathetic from the vagus, hepatic branch from the vagus, and systemic, it takes blood nerve supply from T7 to T9. Look here, very important. Why the gallbladder pain makes pain at the inferior angle of the right scapula? Because it takes the same dermatomes of T7 to T9, which is the systemic sympathetic supply for the gallbladder from T7 to T9, and the brain misunderstands it as it is like somatic pain, and the pain is referred just below the angle of the right scapula. This is the referred pain, not radiating pain. The other sensory somatic supply, it takes from the right phrenic artery. Right phrenic 3, 4, 5 keeps the diaphragm alive. 3, 4, 5 keeps the diaphragm alive. This is the nerve supply of the diaphragm, which keeps the diaphragm working. It also gives the gallbladder. That's why pain in the gallbladder makes pain in the tip of shoulder, because it is the same nerve supply to the dermatome of the tip of shoulder. The same nerve supply for the dermatome of the tip of shoulder. It takes C3 and sometimes C3 and C4. It is the tip of the shoulder. So here is the referred pain from the sensory supply of the phrenic nerve. So that's why we know now why inferior angle of the right scapula, T79 dermatome somatic sympathetic supply. Why pain in the tip of shoulder or right shoulder? Because it takes from sensory somatic supply from the right phrenic nerve 3, 4, 5, which is the same dermatome segment of the supraclavicular nerve. Supraclavicular nerve supplies this area and so gives referred pain to. Extrahepatic biliary tract. So we have bile duct inside the liver, go outside the liver to form the right and left hepatic ducts, the unit to form the common hepatic duct, which has a 4 millimeter diameter by ultrasound, and then go to join the cystic duct to form the common bile duct. Cystic duct and the common hepatic duct. The common hepatic duct has 3 portions. One portion just above the duodenum, which is called supraduodenal, and another portion go behind the duodenum, which is called retroduodenal, and another portion just below the duodenum, which is called infraduodenal, and then intraduodenal part, which is the sphincter of Oddi, which opens in the posteromedial surface of the second part of the duodenum, 10 centimeters from the pylorus, 10 centimeters from the pylorus. Foramen of Wenneslow. We discussed about foramen of Wenneslow. This is the free, most important here, it is the free border of the lesser omentum containing the portal vein posteriorly. As we said, this is the main structures. Hepatic artery, anterior and to the right. Common bile duct, anterior and to the left. And then posterior to them are the portal vein. This is the main structures of the epiploic foramen entrance, and this is the free border of the lesser omentum. Pringles maneuver, this is the maneuver we use to stop bleeding, exactly like the surgeon here making. You can put your finger and compress between the thumb and the index finger, or you can put a vascular clamp till you stop your bleeding. How to approach this? By just a small opening in the lesser omentum or the gastrohepatic ligament. Lesser omentum or the gastrohepatic omentum. Spleen, also we just know about the spleen, that the spleen is very famous, but it's numerical mnemonics, 1, 3, 5, 7, 9, 11. 135 is the inches of the size of the spleen. It weighs 7 ounces, about 150 to 200 milligrams, and it is in the left hypochondrial space or region, just opposite the 9th and 10th and 11th costa, the reps, and the long axis is parallel to T10. The long axis is parallel to T10 as we see in the diagram. What is the surface anatomy of the spleen? 2 transverse lines at the 9th and 11th rep. 9th and 11th rep. 2 transverse lines and 2 vertical lines, 1 mid-axillary and 1 from the inferior angle of the clavicle. Inferior angle from the clavicle. This is the surface anatomy of the, inferior angle of the scapula. Inferior angle of the scapula, downward, mid-axillary line, downward, and it is between these 2 lines and between 2 transverse lines passing through the 9th and 11th rep. 9th and 11th rep. What is the peritoneal covering of the Spleen, the spleen is completely covered by peritoneum. Completely covered by peritoneum. Very important here, and the question in the exam, ligaments of the spleen. The spleen has two important ligaments. I'll talk about the most two important things. It has one, it's called pharyngocholic ligament, and this just supports the spleen, pharyngocholic ligament. It is not in direct contact with the spleen. It is not part of the spleen, but it just restricts the mobility of the spleen to move. This ligament prevents the spleen from moving downward during enlargement, and this makes the spleen to move to the right iliac fossa during enlargement. What is the most important two ligaments? One ligament we talked about, this is the stomach cut. This is the stomach. It's cut here. The stomach, this is the dotted line, is the stomach, and this is the gastrosplenic ligament containing just short gastric vessel to the fundus. And this is the first ligament we have to divide and incise during splenectomy. Then you reflect the stomach or drag the stomach away from your field. You will find behind the lieno-renal ligament, this one, or spleno-renal ligament, this continue to the kidney here, to the kidney here. It passes to the kidney. So this is called lieno-renal ligament. The lieno-renal ligament contains the tail of the pancreas. Maybe here it's clear. This is the fundus of the stomach, and this is the gastrosplenic ligament we cut and then open this area, which is the lesser sac, and then we find another ligament here, which is the lieno. This is the kidney, lieno-renal ligament. In this ligament runs the splenic artery, and together with it runs the tail of pancreas. And very common site of injury of the tail of pancreas during ligation of the lieno-renal ligament. When we cut the lieno-renal ligament, sometimes the patient you will find in the drain serous fluid, and just make analysis, you find amylase is very high. So this is, or lipase sometimes very high. So this is a lieno, or as is a pancreatic fistula or pancreatic tail injury making this problem. So take care while cutting the gastrosplenic ligament from injury of the fundus of the stomach, and take care from cutting of the lieno-renal ligament from injury of the tail of the pancreas. This is the most important points about the spleen here, the ligaments, this ligament, and this ligament. Very important. This is a pharyngocholic ligament. It is in contact, but it is not attached to the spleen, but it prevents the spleen from going downward and directs the spleen to the right iliac fossa during enlargement. What is the blood supply of the spleen? Splenic artery runs along the upper border of, posteriorly by the way, the upper border or posterior, the upper border of the pancreas. Splenic vein runs behind the pancreas, and both of them are liable for thrombosis in case of acute pancreatitis. Okay, the splenic vein joins the superior mesenteric vein to form the portal vein and the portal circulation just behind the neck of the pancreas, just behind the neck of the pancreas at the level of L1. Pancreas. Pancreas is a retroperitoneal organ at the upper part of the posterior abdominal wall. Okay, it's in the concavity of the duodenum and then extend to the left till it reaches till the tail of the pancreas. it is related anteriorly to the lesser sac. So if you want to approach the pancreas, you have to open the lesser sac. Head of the pancreas is related posteriorly to the CPD. We said that the common bile duct, there is an infraduodenal structure passing behind the head of the pancreas, and the IVC and the aorta, posterior relation to the head, CPD, IVC, and aorta, and they are easily infiltrated. They are easily infiltrated during cancer head of pancreas to close the common bile duct or infiltrate the IVC and the aorta, and causing obstructive jaundice if it is obstruct the common bile duct. Neck of pancreas, the most important thing about it, it is the site of junction between superior mesenteric and splenic vein to form the portal vein at the level of L1. Body of the pancreas related anterior to this lesser sac and the posterior surface of the stomach, and it is the site of pancreatic pseudocyst. And you can see it in like this one. This is the lesser sac filled with the pancreatic pseudocyst. By the way, in X-ray, lateral X-ray with gastrographene, you can find the gastrographene filling this part of the stomach and what is called in the lateral view C-shaped stomach because of a tumor or a mass from the pancreas. Posterior relations, splenic artery and vein. Splenic artery runs at the posterior upper border of the, just posterior to the upper border of the pancreas, and the splenic vein just behind the pancreas, and they are very common to have splenic vein thrombosis during pancreatitis. Tail of pancreas, surgical importance, may be injured, as we say, during ligation of the lieno-renal ligament, during ligation of the splenic vein, splenic artery and vein or splenic vessels, which runs through the lieno-renal ligament. So you can injure the tail of the pancreas at this site. What is the ducts of pancreas? Pancreas has two main ducts. Main duct, two ducts. Main duct, which is the duct versing, and accessory pancreatic duct with the duct of Santorini. Duct of Santorini opens separately in the duodenum, proximal to the duodenal papillae and the major duodenal papillae, which is the opening of the main pancreatic duct together with the common bile duct to form the ampulla of Vater. At the posteromedial surface, again, I'm repeating, posteromedial surface of the second part of the duodenum, 10 centimeter distal to the pylorus at the level of L1. Blood supply to the pancreas. We said before, the pancreas takes blood supply from superior and inferior, mainly the head. Like the second part of the duodenum, it takes from above superior pancreaticoduodenal artery, and from below, from the celiac trunk here, and from below inferior pancreaticoduodenal artery from the superior mesenteric artery. Both of them have anterior and posterior branch, and then the tail have splenic branches from the splenic artery, has direct branches from the splenic artery to the pancreas. Direct. What is surgical importance here? That is, the second part of the duodenum shares the pancreas, the blood supply during Whipple's operation. That's why we remove the duodenum with the head of the pancreas. Okay, because it has the same blood supply. Lymphatic drainage, mainly through the, as it takes blood supply from the celiac and superior mesenteric, so it gives nerve supply or lymphatic drainage, sorry, to the superior mesenteric and celiac lymph nodes. Nerve supply, the same, we said that the coming with the foregut and midgut takes from the vagus, which is secretory, and takes sympathetic from the greater splanchnic nerve, like the foregut, which is concerned with pain during pancreatitis. Greater splanchnic nerve to the celiac trunk or the celiac ganglia. Okay, let's go through the kidney first. I think Dr. Salah, I think finished with you the pelvis, but I'll just maybe take only the kidney. We have two retroperitoneal organs on right and left, which are the kidney. The left one is a little bit higher than the right kidney. The right kidney is just half an inch lower because of the pressure of the liver. So you find the right kidney is a little in a lower position than the right one. Embryologically, they have fusion of mesonephric, which is a collecting duct, with the metanephric of the secretory ducts. That's why here, what is the pathophysiology or pathology of polycystic kidney? This fusion doesn't occur. This fusion between the mesonephric collecting duct and metanephric secretory ducts doesn't occur. That is the cause of polycystic kidney. Polycystic kidney. And even also another congenital anomaly, which is non-rotation of the kidney. You will find the hilum directed anteriorly, but normally the hilum will be directed medially. Very important in question is this one. What is the pedicle of the kidney? The pedicle of the kidney confirmed mainly from the renal vein anteriorly, the renal artery in the middle, and the renal pelvis and the start of ureter is posteriorly. That's why in renal pelvis stone, the approach of the kidney is not from intraperitoneal. The approach is posterior approach from the loin. Posterior approach, because in anterior you'll find the vein, in the middle you'll find the artery, and the posterior you'll find the pelvis. Here's radical nephrectomy. We do it anterior approach because we want to get the vessels first. But in nephrolysotomy, we have posterior approach because we want to remove the stone or to approach the pelvis from posterior. Blood supply, renal artery at the level of L1, L2, and then go to the renal vein, renal artery, and the renal vein. The right renal artery is longer than the left renal artery. On the controverse is the left renal vein is longer than the right renal vein. What is the relations of the kidney? Relations of the kidney. This is important. You have to know. If you just know it from the diagram here, you will never forget again. You will never forget again. Let's go to the relations of the right kidney. Right kidney relations. Above, suprarenal. Very easy. We say that the duodenum takes the hilum and the medial border of the kidney. So this is the duodenum. Outside the duodenum is the liver, and below is the colic flexure and coils of the small intestine. So suprarenal gland above, medially is the second part of the duodenum, laterally is the liver, and below is the colic flexure and coils of the intestine. Left kidney, the same, suprarenal above, and then spleen outside. The other one was the liver. Cause of the jejunum and colon, this can be considered as one part. Splenic flexure and cause of the jejunum. Here was the hepatic flexure and cause of the intestine. And what's more important is the middle part, which is the pancreas. Pancreas. So suprarenal above, spleen above and lateral, stomach in the middle. Stomach takes a part of the anterior surface of the anterior relations of the kidney. Pancreas, descending colon and cause of the jejunum as well. What is the capsule of the kidney? The kidney has what is called important gyrotous fascia or Zucker-Candle's capsule, which is a very tough capsule, prevents spread or delays the spread of any cancer of the kidney. And it also have inside the perinephric fat and then a tough or an adherent fibrous capsule. So the kidney is surrounded by an adherent capsule, fibrous capsule, just around the kidney itself. Outside of it is the perinephric fat and then the gyrotous fascia or the Zucker-Candle's fascia. This fascia is not closed inferiorly, by the way. This is closed around the kidney, all around the kidney except inferiorly. That's why ptosis of the kidney can happen of any trauma or any traumatic injury. Ptosis of the kidney can happen through this non-fused part of the gyrotous fascia. Suprarenal gland. It's explained also in the parathyroid and the supra and the adrenal gland of pathology and anatomy. The suprarenal gland simply is composed from cortex and medulla. The cortex has 3 layers, which is zona glomerulosa, zona fasciculata, zona reticularis. Each one is responsible for secretion of some hormones. Like we know the mnemonic, we can say zona glomerulosa, zona fasciculata, zona reticularis. GFR will give us mineralocorticoids or aldosterone. Okay, and then zona fasciculata will give us glucocorticoids or cortisol, and zona reticularis will give us 6 hormones or gonadotropins or androgens as well. So aldosterone, glomerulosa, GFR, fasciculata will give us glucocorticoids and cortisol, and zona reticularis will give us androgen and 6 hormones. Important in anatomy, this is a physiological part, important, and also the medulla will give us the catecholamines, catecholamines. Blood supply to the adrenal gland, the arterial supply, it has 3 arterial supply, but only 1 venous drainage. Arterial supply, superior, let's make it a little bit larger. Superior suprarenal artery from the inferior phrenic artery, which is the first branch of the aorta at the level of T12. Superior from the inferior phrenic artery. The middle comes direct from the abdominal aorta. The middle suprarenal comes direct from the middle aorta, and the inferior comes from the renal artery. So inferior phrenic, superior, direct from the abdominal aorta, right branch, and the inferior comes from the renal artery. Venous drainage is just a single branch, but put in mind, here is the single suprarenal vein go direct to the renal vein, but here single suprarenal vein go direct to the IVC on the right side. So on the right side, the right renal vein drains in the IVC. On the left side, the right suprarenal vein drains into the right renal, on the left suprarenal vein drains on the left renal vein, The ureter, we have two ureters from the kidneys, one from each kidney. It is a collection of 10 to 12 minor calyces to 3 major calyces to form the ureter. This is not important to us. Length of the ureter is about 25 to 30 centimeters. Its diameter, it's about 6 millimeter. The ureter is a retroperitoneal structure, most important, starting from L2 to L5. Where to look at the ureter? In the X-ray or in the eye view, you have to look between L2 to L5 transverse process. L2 to L5 transverse process, searching for the ureter, because after this, it will pass above the bone of the sacrum or the sacroiliac joint specifically. So it has a peritoneal, abdominal part and pelvic part, and then intramural part. The abdominal part, you look in the X-ray between the transverse process of L2 to L5. Okay? Then, the pelvic part. It lies in front of the bifurcation of the common iliac arteries. Very important question in the exam. In front of the bifurcation of the common iliac arteries, immediately in front of the sacroiliac joint. Give these three related structure. Ureter, pelvic part of the ureter, in front of the bifurcation. Okay, and just behind them is the sacroiliac joint. These are three structure at the same point. This is the pelvic part. Then it goes to the pelvis to pass. Very important. What is the relation between the ureter and vas? What is the relation between the ureter and uterine artery? The ureter in both cases passes beneath of them. Passes beneath of them, and we say this is a water under the bridge. So we consider the uterine artery as a bridge, and then the ureter is a water passing to the bladder below the uterine artery, and we consider the vas deferens as a bridge, and the ureter go and join the bladder below the or beneath the vas deferens. And both of them beneath, posterior and beneath of the uterine artery in both males and female. Don't forget this relation is very important in exam. Again, lastly, the intramural part inside the bladder. It takes an oblique course to go inside the bladder in the posterior surface or the base of the bladder. Very important that the ureter joins the bladder in the posterior superior surface of the base of the bladder. The ureters join the base of the bladder, posterior superior surface. This place, posterior superior. This is posterior superior place. This is posterior superior. This is the base of the bladder. The ureter joins the base of the bladder. This is the base of the bladder. Okay? What is the blood supply of the ureter? The blood supply of the ureter is divided in 3 parts. The upper third takes from the renal artery with the pelvis of the kidney. The middle third takes from the gonadal and aortic and common iliac branches. Gonadal, aortic, common iliac branches. And the lower third takes from the vesical branch in male or uterine artery in female. Vesical artery in males and uterine artery in females. Very important question in the exam. What is the relation between the ureter and the gonadal vessels? Take care which one he asking about, if the ureter to the gonadal or the gonadal vessel to the ureter. However, the ureter comes from outside and then cross behind the gonadal vessels and then become medial to the gonadal vessels at the site of crossing the common iliac artery, the bifurcation of the common iliac artery. In the exam, he asked, at the site of the bifurcation of the common iliac artery, what is the relation of the ureter and the gonadal artery? The ureter is medial to the gonadal arteries. But what is the course? The course is lateral, posterior, medial. Ureter to the gonadal. Ureter to the gonadal comes from lateral because it is a lateral structure, and the gonadal vessels come from inside. So it is come lateral, then cross behind, then become medial to join the bladder. Identification of the ureter in X-ray. Tips, abdominal part is the tips of the transverse process of from L2 to L5. This is the abdominal part. In front of the sacroiliac joint is the pelvic part, and at the ischial spine, just medial to the ischial spine, it is the site of intramural part, entrance of the ureter of the in the urinary bladder. So this is the intramural part. This is site of stone you can look for. Let's talk to another important topic, which is called sites of ureteric constriction. Sites of ureteric constriction and how to know. And this is the site of impaction of stones. We have 3 main sites the stone can be impacted in. The first one is the pelviureteric junction at the level of L2 transverse process. Level of L2 transverse process. The second site is the inlet of the pelvic brim at the bifurcation of the common iliac artery. I said the bifurcation of the common iliac artery is very important landmark for the ureter, and it's a site of constriction of the ureter, which is in the X-ray or the CT. You can look just in front of the sacroiliac joint or the site of the bifurcation of the common iliac artery. The last constriction is the vesicular junction, intramural part, which you have to look in the X-ray just medial to ischial spine. This is the ischial spine. This is the ischial spine, and you have to look here. This is the ischial spine, and you have to look here. This is the third part of constriction of the ureter, and this is sites of impaction of the renal stones. Okay, now I think Dr. Salah finished with you the pelvis. Thank you and wish you enjoy this lecture about abdominal anatomy. For any question, you can contact me anytime, and thank you. Again, back for very important short notes about the blood vessels of the abdomen, mainly. we are also going to talk about the abdominal aorta. We just finished most of it, but just to make a summary for the abdominal aorta. The abdominal aorta starts at T12, opening of the diaphragm, and ends by bifurcation to two common iliac arteries at the level of L4, and it passes from L1 to L4. Okay, so start at T12, ends at T4 by bifurcation and two common iliac arteries. What is the branch of the abdominal aorta and its level is very, very, very important. No exam, at least 2 to 3 questions about levels of branches of the abdominal aorta. Inferior phrenic vessel, this is the first branch coming from the abdominal aorta, and it is at the upper border of T12. So T12 is the origin of the aorta, just it is out of the diaphragm. It gives the inferior phrenic vessels below the diaphragm. At the same level, at the lower border of T12, it gives the celiac artery, which is the main blood supply for the foregut. Just below, at the level of L1, it gives the superior mesenteric artery. So celiac, T12, superior mesenteric, L1, the most important also, the inferior mesenteric, which is the L3. Renal and suprarenal. We said that the middle suprarenal comes from the aorta, but the superior comes from the inferior phrenic, and the inferior comes from the renal artery. This is the 3 branches of the suprarenal gland. So the middle suprarenal comes from the aorta at the level of L1, at the level of L1 from the sides. By the way, celiac, superior mesenteric, and inferior mesenteric are anterior branches to the GIT. But inferior phrenic is bilateral branches. It is double branches from both sides. Middle suprarenal from the side, on both sides of the artery. Gonadal vessels, renal artery will be at the level of L1, L2. Also, these are paired branches. Gonadal at the level of L2, just below the renal artery, at the same level of L2. So L1 will give the middle suprarenal, L12 gives you the renal, and the gonadal vessels just below it at the level of L2 gives also small branches from L1 to L4 bilaterally, paired branches to the posterior abdominal wall. Most important is the inferior mesenteric at the level of L3. And lastly, this middle branch, this is single branch, which is the median sacral. Sometimes they say it is an inferior branch or an anterior branch of the aorta, just at the bifurcation. So at the L4, it bifurcates to right and left common iliac arteries and gives a branch of the median sacral artery. Here the same. This is the most important. T12 gives us the celiac, L1 superior mesenteric, L3 the inferior mesenteric, and L2 the renal arteries, and then bifurcation at L4. This is a very important diagram and very nice diagram to know the vessels of the important vessels of the abdominal aorta. Common iliac artery, external iliac, and internal iliac. This is our with the pelvis sector with Dr. Salah. Lastly, we finish with the inferior vena cava. Inferior vena cava start at the level of L5. By the way, we start from down. We start from down upward because this is a venous drainage. It starts on one vertebra below the aorta, it starts at the level of L5, and then, as we said, it's open in the diaphragm at the level of T8. Very important, don't forget, please, T8. So the aorta is T12, the IVC is T8. In between is the esophagus at the level of T10 in the central tendon of the diaphragm. Central tendon of the diaphragm. Go to the branches of the abdominal inferior vena cava. As I said, it started from below as common iliac veins forming the inferior vena cava. It has some lumbar veins corresponding to the lumbar arteries from L1 to L4 in the aorta. Here is from L1 to L5 lumbar veins. The same gonadal vein at the level of L2, the same as L2 in aorta. The gonadal vessels come from L2. Right suprarenal, we have only one suprarenal vein. We have only one suprarenal vein. At L1, we have the renal veins. So you have right and left renal vein, but you have only right suprarenal vein. Remember what we said, that the suprarenal vein on the right side drains direct to the IVC, but on the left side, it is drained in the left renal vein. Left renal vein, left suprarenal vein drains in the left renal vein on the left side, but on the right side, it drains directly to the IVC. Then at T8, just before its entrance, we have the hepatic veins, the 3 hepatic veins we talked about in the venous drainage of the liver. Another important point just to remember here, look at me. Left gonadal vein and right gonadal veins. Very important to know that the right gonadal veins go directly the same like right suprarenal and left suprarenal. Right gonadal veins, the same like right suprarenal veins, go directly to the IVC, but left gonadal veins, the same like left suprarenal vein, drain into the left renal vein. That's why it is very common to find varicose veins in males. The varicocele is very common on the left side than the right side because it drains in a smaller vein, but the right gonadal vein or right gonadal vessel drain into the IVC, which is the main branch. So very common to find left varicocele, by the way. And sometimes they said if you didn't find left, if you find varicocele, you have to try to find that the left is much start earlier and much bigger than the right side. Okay, this is very important note to know. Thank you again. We finished the vessels, the main important vessels for the abdomen. Thank you.